Donia, a little bit about your treatment journey. So, what kind of, if you don't mind sharing that, what kind of treatments did you go through after you met Dr. Iskander? What were the next steps for your treatment?
So after my debulking surgery, which I was told had no evidence of disease, so it was optimal, I began chemotherapy with Taxol and carboplatin, and I also went on a clinical trial with a PARP inhibitor that Dr. Iskander felt was a really good match for me. And I did dose-dense therapy, so I was scheduled to do 18 chemos, treatments, infusions, and I was able to complete 17 of them. But
very nice.
Yeah.
You're right. That's okay. I think that's a lot. Dr. Iskander, tell us a little bit about therapy for ovarian cancer. What is the normal what are the treatment steps that you take from the beginning for kind of staging the cancer, and then what are the treatment options available for patients out there?
So the first fork in the road is really whether or not you're able to proceed with primary surgery or if you need to start with what we call neoadjuvant chemotherapy. And that depends on many factors. It depends on how physically fit a patient is, whether they have medical conditions that would preclude a big operation, where the disease is felt to be or to affect, and that's predominantly based on clinical exam and imaging. If you feel like you can successfully remove all the tumor, which is the goal of a primary surgery, is to remove all the visible disease, then you can proceed with a primary operation, again, in the context of a medically fit patient. If, for whatever reason, the disease is unresectable, if there's widely metastatic disease in the lung, or if there's multiple lesions in the liver, then those patients, you would get a biopsy to confirm their disease and also to help you figure out the germline and somatic BRCA status now, which is still relevant. And then you would offer them primary neoadjuvant chemotherapy. And that could be done on a clinical trial if one is available at the institution where the patient's being treated, or with, again, standard carboplatin, paclitaxel. And some people incorporate a drug called bevacizumab or Avastin in that setting. And if you operate first, then once surgery's done, you talk about treatment. And again, those treatment options are clinical trial or carboplatin, paclitaxel with or without bevacizumab therapy, and then also the PARP inhibitor option for appropriate patients who have a BRCA1 alteration, or BRCA1 or 2, excuse me.
So it's kind of tailored towards every patient. In a way, what you do, there could be different options. There could be some target therapies like you're talking about. There could be chemotherapy to get them through that surgery with a combination of the above. Dr. Hurst, for patients going through chemotherapy, what kind of emotional and psychological changes that can go through, and how can patients deal with that?
What we find is for a lot of patients, there's a lot of, still the fear and the worry sort of leading up to meeting with your physician, then getting a plan, things start to calm down. And then there's, again, sort of another peak of anxiety around before you have surgery, before you start chemotherapy. But then once things start to happen, for many folks, there's a sense of like, okay, now we're on the road, now we're doing something about it. The cancer was still growing or still attacking me, but now we're doing something about it. And often a sense of relief can come. For folks who have a lot of side effects to chemotherapy or have a more complicated postoperative course, or the physical symptoms can crop up. And when we're not feeling well physically, that tends to also impact sort of our emotional strength and our emotional tolerance.
Right.
So we find that treating, whether it's nausea, pain, constipation, sort of the basics, if we can keep our physical self feeling well, we are a little more strength emotionally to deal with the ups and downs that we're facing.
Donia, so did you can you share with us some ups and downs that you faced? How did you deal with them while you were undergoing chemotherapy or therapy in general?
Well, one of the things I did that I wanted to maintain as much as I could a sense of normalcy, and part of that was I was told I would be able to keep my hair. And so I did a cold cap treatment.
Yes.
And 17 times.
And that is intense. The cold cap is not.
You must really want that hair.
You were determined.
I was, but it was nice for me. My identity was, my hair's part of my identity,
Right.
and I really respect women who, whatever journey they decide to go on. But for me, it was really nice to go out on a Friday night. My husband and I always go to the movies on the weekend, and to just feel like myself. I could kind of put cancer in a box, and So that was a nice thing to find out you don't have to lose your hair. I probably lost about 20%. That's what my hairdresser said. And so that was a perk. But challenge was probably some complications that I had. I had 2 obstructions, intestinal obstructions due to scar tissue that required hospitalization and surgery during the time I was having chemo. And that resulted in dose delays. And also because of the toxicity, I had dose reductions. And so those weighed on me because I felt like if we're going to do this, let's do it. I mean, just give me the stuff and let's really go to battle. But so that weighed on me because I worried that my body wasn't fighting hard enough, and they were having to treat me more and more carefully. But
that's fairly common because when we test these drugs, they're just testing a small amount of patients, and then we give them to hundreds and thousands of patients, and then there has to be truly per patient dose adjustment, and that's where expertise of people like Dr. Skander comes in, who can kind of see what you can tolerate and kind of dial the chemotherapy to with your body's reaction.